Hi, my name is Shalene Shah, and I'm from Princeton, New Jersey. I want to thank all of you for taking the time today to connect with me about Orthodontics 101. This webinar is financially compensated, but everything that's shared today is something that lends itself to our practice efficiency and yielding the treatment outcomes that we want for all of our patients and affording them the experiences not only they deserve, but what they love. And I want to start off our conversation with this concept of accuracy. I would submit to all of you that accuracy plays some kind of role in your personal and professional lives. In our professional life, if we took a look at a patient like Chin, who presented with this type of occlusion, where we can see that there's crowding on the upper as well as on the lower. There are multiple areas of attachment loss. There are multiple missing teeth. We also can see that there's an edge-to-edge bite. Taking a look at the occlusal views, we can see and appreciate the extent of the crowding in the anterior, on the upper, as well as on the lower. We can see also positionally the rotations of the dentition, as well as the inopportune axial forces and positions of the teeth. The question that we have in front of us, if we're looking to accurately deliver the care that Chin deserves to have the treatment outcomes that are going to be long-term predictable and stable, can we look at these photos alone to determine whether extractions are needed? Do we understand what the final position of the teeth need to be within each arch, within respect to the bone, and with respect to the opposing arch to establish a healthy static and functional occlusion? Do we understand if we have the space requirements to be able to fit the teeth within the given infrastructure? Or would we be violating that during our treatment, afterwards, or posing a risk that would actually not unveil itself for years after the therapy is complete? Which begs us to understand not only the positioning of the teeth, but where are those teeth with respect to the given skeletal infrastructure? And while we were looking to mitigate risks to ensure that we achieve that healthy bite, did we in fact introduce more risk or not address enough of the risk that was present in the etiologic factors when the patient had sought orthodontic treatment with us, and as a result put them in a position that was either no better than when they initially had come to us or in a worse off scenario? If we take a look at the pathway of a new patient in our office, when they come in, they're going to express the reason why they're there, the chief concern, the reasons that are motivating them to take that next step forward for treatment and care. When we take a look in the mouth, we can begin to see and appreciate a variety of things. How does the lower arch form look? How does the upper arch form look? Is there crowding on the lower and the upper? How do the maxillary and the mandibular arches relate to each other? What is the overbite? What is the overjet? Are there cross bites that are present? What is the molar classification? Is there wear on the teeth? What are the excursive patterns? Because we can have a smile that looks great, but if it cannot function great, it's not something that's going to be viable long term. We also can appreciate the joints and how it functions. I like to say that there are 4 functioning systems that have to be in harmony with each other. It's the skeletal, it's the muscular, it's the neural, and the dental. What can happen is that even a minor risk where all 4 are not working harmoniously together can result in one or more of those systems being harmed long term. So we need to be cognizant of how they all interact with each other. We also could take a look at the attachment apparatus. We now recognize that it's not just tooth alignment alone. It's in fact the tooth alignment being in a proper position such that it's in a symbiotic relationship with the underlying bone and attached tissue. My dad always said, look to history for answers for the future. If we see that in the absence of periodontal pathogens, that there are areas of recession and there's areas of horizontal bone loss, we must ask ourselves that what was the true etiology of that clinical manifestation? Was it potentially a tooth position issue? Was it an issue where the bone and the tooth interface was an inopportune scenario where long-term it wasn't going to be able to sustain that type of load and forces? So this is going to be able to provide critical information not only to us as the treating practitioner, but also to be able to communicate to our patient why they're seeing what they're seeing, and really what is the health value and what is the drive to pursue orthodontics to be able to achieve that stable, healthy bite long term. We also recognize in our 3D imaging when we take our CBCTs that the teeth not only exist within the bone, but within a functioning system. So we can look at our joints, as well as begin to get an appreciation of the airway. And I recognize within the profession that airway can be a controversial topic. But what I submit to everyone is that if we have the ability to take a look at the volumetric airway at one static point and identify that maybe there's something that could be a point of discussion, it's our obligation to be able to bring that up. I'm not suggesting that we're going to be the end all be all in terms of the role in increasing that airway, but I'm also not going to be dismissive of the fact that we can play a role. So what is incumbent on us as orthodontic practitioners, or practitioners that are going to be practicing orthodontics for the benefit of our patients, is very simply, we need a consistent, reliable, and easy method for aligner treatment planning. Equally as important, if we're going to do these sound diagnostics, we're going to understand the etiologic factors, we're going to come up with the diagnostics of what we're seeing, and subsequent to that, a treatment plan that is to execute the precise movements of those teeth. We need to ensure that our vehicle or treatment modality method is going to be consistent, efficient, and it's a system that's always going to yield and produce quality results. And for our practice, for the benefit of our patients, that begins with accurate scans, leveraging the prime scan, and then utilizing SureSmile aligners. This ultimately brings us back to this concept of accuracy. You can see the whole host of information that we look to achieve for our patients, not only in know-how, not only in execution, but also in the patient experience. Because you see, accuracy is not only an expectation for ourselves, it's for the people that journey with us on a day in and day out basis within our practices. And those people are our team. And then finally, of course, by our patients. This ultimately leads to treatment that's going to be both predictable as well as stable. And more importantly, it's also going to be long-term. There's a figure by the name of Jim Rohn who said, accuracy builds credibility. While we look to deliver in a precise and accurate way for all of our patients, this is a very important concept about credibility. Credibility, of course, is something that we want to earn from our patients. That ultimately manifests itself as buy-in for treatment in the process and in our hands. But equally as important is the fact that we want our team to believe in what we are doing. We want it to be more than just a job. We want their journey to be something that they feel that they're adding more value to people's lives, not in just that moment, but also much more and much further beyond when their treatment is finished. And finally, if it's not for our patients and it's not for our team, in the least, it really should be for ourselves. When we wake up every morning, we should believe in what we are doing and the changes that we are looking to make. So today, I'd like to go into Orthodontics 101, back to the basics. What is going to root us in the foundation of knowledge and know-how to ensure that we can see what the patient presents and where the changes need to be made, and how to effectively communicate that to our patients and identify which cases can be in our hands that can yield the success not only that we want for ourselves, but what we want for our patients. Our discussion points are going to focus on an introduction to orthodontics. And don't worry, I'm not going to take us back to 4 years of dental school in the depth of orthodontic courses that you had. Those actually are going to serve as the foundation for the salient points that I'm going to use as a reminder for how our orthodontic cases need to be thought of and how they need to be set up. And then subsequent to that, we want to talk about case selection. What is going to make you successful on Monday? And we call it the Monday morning ready, because while we have this opportunity to advance our own knowledge and enable our own growth, we want that to translate into action. So what we're going to learn today and what we're going to speak about together needs to help us be Monday morning ready for our first patients. And then finally, case setup and communication. How can you take all of that knowledge? How can you take all of that work that you so diligently did for your patients and make sure that you can effectively communicate that to the team that's looking to support you in your aligner therapy? So orthodontics. Let's start our introduction with a simple but very important question. What is orthodontics? And if we want to answer that at a 30,000 foot level, very simply, it could be answered as orthodontics is full reconstruction of the enamel. And this is something that is done on a daily basis within restorative dental offices. And I get the question, well, should we look to support general practitioners and restorative dentists doing orthodontic care? My response is that if we fundamentally think about the most important person in this process, which is the patient, then with the correct know-how, the correct understanding, and the correct treatment modality, the answer would be yes. Because we want to look to help the patient achieve the treatment outcomes that they deserve. We want to make sure that they're going to be predictable, long-term, and stable. And as long as the restorative dental team has the understanding to be able to deliver on that, then why wouldn't we enhance the patient experience by keeping them within the restorative practice and also be mindful of their financial investment? So then what is the role of the orthodontist? Well, when we talk about comprehensive care, when we talk about dental facial orthopedic changes, when we talk about seeing children at the age of 7 as recommended by the American Association of Orthodontists, that's the know-how, the insight, and the understanding that the orthodontic team provides. But there are still many cases that are out there where the patient can benefit from the knowledge and the capacity of the restorative dentist to seek that orthodontic limited treatment within their office. And with a synergistic relationship between the orthodontic practices and the restorative dentist, the person that will ultimately benefit is the patient. And both disciplines, both professions can equally succeed with this type of effort. So when we talk about orthodontics, we're not only talking about the teeth, we're making sure that the underlying position of the roots are going to be cognizant of where the skeletal infrastructure lies, and make sure that we're always operating within the dental and the skeletal envelopes of discrepancy. This really will provide a long-term solution where not only the dentition, but the underlying attachment apparatus can coexist in a healthy manner. So let's look at something relatively simple. The act of eating, the act of mastication. If we take a look at this individual that was provided a piece of lettuce to chew, and what she was looking at was addressing the position of tooth number 10. What we can see in the act of chewing is that she is grinding against her teeth. She has an inopportune functional bite. If we compare that to the same patient that is properly treated with orthodontics and restorative care to achieve both the ideal static and functional occlusion, and given that same act of chewing on a piece of lettuce, what we can see is in that power stroke, with the environment that was properly developed, with the understanding of the etiologic factors that she had present that were then addressed subsequent to her treatment, we can see that simple act of enjoying her food can be completed without the destruction of her teeth. So how are we to achieve that? If we were to distill out some of the most salient but yet important parts of orthodontic goals, that can be best summarized with an article written by Dr. Larry Andrews, which is called The 6 Keys to Normal Occlusion. And these are the tenets that we should all be looking to achieve for our patients. And if they are not achievable, then that's a risk factor that needs to be discussed with the patient, or when we engage our orthodontic teams and local practices to be able to help us get our patients to where they deserve. So what Dr. Andrews did in the 6 Keys article was look at 120 non-orthodontic normal males, or our control group. I apologize, normal models. And he then looked at 1,150 orthodontic treated models. And what he found is within the 120 orthodontic normal models, or the control group, and the 1,150 orthodontic treated models, there were 6 specific attributes that he saw in all of the healthy bites. And this is what we're going to use as the foundation for setting up our cases, as well as diagnosing what are the current presentations of the patient and where do the opportunities lie for orthodontic care. So key number 1 is molar relationship. And what he found is that the mesiobuccal cusp of the upper maxillary molar should fall into the mesiobuccal groove of the lower molar. And you see, this is much more impacting than just looking at 2 teeth per side. When you have the correct starting position of the mesiobuccal cusp of the upper engaging with the mesiobuccal groove of the lower, you have subsequently set up success for all of the anterior teeth that come in front of that. So then the upper second premolar will engage with the embrasure space between the lower second premolar and the lower molar. Mesial to that, the upper first premolar or maxillary premolar will engage with the embrasure space of the lower mandibular first premolar and second premolar. And for all of us that look to have a proper canine class 1, This is where it starts. Because you have the molar in an angles classification 1, if there are no tooth size discrepancies, then you should anticipate that canine will land right into that class 1 position. Key number 2 is crown angulation, or otherwise known as tip. So what that means is that if you look at the incisal occlusal or incisal gingival portion of the teeth, what you would like to see in your final setup is that the gingival portion is going to be slightly distal to the incisal portion. For those who look at canine guidance, you know that that mesial tip of the edge of that canine helps significantly in our canine guidance and reducing non-working interferences. So when we get our lab setups back, we want to make sure that we're looking for this feature in the final occlusion. Key number 3 is crown inclination or torque. And we're going to break this up into the anterior and the posterior. For the anterior teeth, we want to have positive torque on the anterior teeth. When we have that positive torque, we have that nice little protrusive runway to not only allow for mutually protected occlusion, which is the posterior disclusion upon opening, but also to make sure that as the joints slide down the fossa, they are all working in harmony. When we take a look at the posterior teeth, we want to ensure that those posterior teeth are going to be upright or at most just a little bit of lingual inclination. Key number 4 is to ensure that there are no rotations, no increased surface areas or opportunities for plaque or biofilm to be able to populate without or increasing the inaccessibility for the patient to be able to clean that area. Key number 5 are no spaces. We can all understand and appreciate the value of having tight contacts. And then finally, key number 6, ensuring that we have a relatively flat occlusal plane and not an exaggerated curve of spee. So these are the 6 keys to normal occlusion, ensuring that our starting position of the molars are in an angles classification 1, ensuring that our crown angulation or the tip of our teeth are going to have a slight mesial angle at the occlusal or incisal surfaces. And key number 3 is ensuring that our anterior teeth are going to have a positive torque or inclination. Our posterior teeth are going to be upright or slightly lingually inclined. And for those of you who already picked up on this, this is addressing the curve of Wilson and ensuring that we have no non-working interferences when we're moving right and left. Key number 4 are no rotations. Key number 5 are ensuring there's no spaces for food impaction and to ensure that the natural dentition and the salivary flow to help keep the oral environment clean can work efficiently as it's designed. And key number 6 is ensuring that our occlusal plane is relatively flat or at most a very mild curve of spee. So let's take a look at a patient example. This is Abby that presented to our office. And these are her intraoral photos. I'm sure there's some things that you're catching right now at an initial glance. This is a perfect case to dissect with the Andrews 6 keys. So if we take a look at key number 1 at the molar relationship, what we can see in the green line and the blue arrows is where the teeth should be. If we compare it then to where the teeth are, we can see that everything is either shifted forward on the upper or shifted back on the lower. And this is, as most of you know, called a angles classification 2, molar and canine relationship. If we take a look at key number 2, the crown angulation or the tip, we can see that The premolars do have that slight mesial inclination. The upper left first premolar, or the upper left 5 in the orthodontic world, is excessively mesially tipped, however, and then the upper left 3, or the upper left canine, is exactly the opposite of what it ideally should be. It has a distal incisal tip compared to the gingival portion of that clinical crown. If we take a look at crown inclination, what we can see is on the upper anterior teeth very visibly that the upper anterior teeth, instead of having the positive inclination, have a negative torque or negative inclination on the teeth. If we look at the posterior teeth, we can see instead of them actually being upright or just a slight lingual inclination, we can see that there's an excessive inclination towards the palate or the tongue. If we look at that in the CBCT version, we can see even more information that's concerning. So not only is there an excessive inclination or torque on those posterior teeth, but positionally, body position of those lower molars are infringing upon the facial or the buccal cortical plate. This is an inopportune position for these teeth and the underlying bone long term. Those teeth should actually be positioned in the center of the buccal and the lingual cortical plates to ensure not only viability of the dentition, but also the underlying attachment apparatus. If we take a look at the occlusal views, looking at the rotations, we can clearly see that there are multiple teeth that have rotations. If we take a look at spacing, we can see that there are a few areas where space exists. And for those astute and observant eyes, we can also see that some of that space is resulting and perpetuating due to a tooth size discrepancy. So this is a true ortho-restorative case. When we take a look at her occlusal plane, this is one factor that we don't have to address. It's relatively flat. So we can begin to understand so much about Abby's case just by looking at the intraoral photographs. We can leverage these photographs when we talk about effectively communicating the value of what our team will be adding when we do orthodontics for Abby. We can present that the upper teeth are slightly back. We can talk about the upper teeth and the back and the posterior are slightly lingually inclined. We can talk about before the treatment that there exists a tooth size discrepancy in that space that you have been seeing, Abby, all this time on tooth number 7 is a result of it being diminutive. And those factors begin to not only lend itself to accuracy in the way that we're seeing our cases, the way that we are planning our cases, but it's also building that credibility that our patients are looking for when they are vetting whether our team, our hands, and our know-how are the right place where they want to have their care. And ultimately, when we have done our due diligence, when we have made that connection, we can make significant changes like we did for Abby in timeframes as short as 16 months, which included not only orthodontics, not only restorative, but also orthognathics, unveiling the skeletal class 2 relationship and getting that mandibular advancement to the right position, understanding that there was a tooth size discrepancy that was not only contributing itself to space, but also to positionally the rotated teeth that we had seen clinically. And ensuring that we are able to achieve arch integrity, derotating all of those teeth, ensuring that we have tight contacts all the way around, and providing Abby the final treatment and the treatment outcome that is going to be long-term, predictable, and stable. And one that she not only sought out, but the smile that she loved. So simply put, but still profound and important, is that orthodontics is full mouth reconstruction of the enamel. This is something that you do on a daily basis. You understand occlusion. You understand how to manage that when there's tooth deterioration, whether it's due to caries, attrition, or otherwise, and how to rehabilitate that. What we just did is we put down the essential pillars for a orthodontic outcome that's going to be long-term, predictable, and stable. And what we now need to discuss is the treatment modalities. There are many modalities that are out there for orthodontics, whether it's lingual braces, buccal braces, or facial braces, whether it's going to be metal-based or it's going to be porcelain or ceramic-based, and aligners. And what I want to focus on today are the aligners. While every treatment modality has its benefits, what we are increasingly seeing is that people are more aware of their teeth. They understand the value of the health of their teeth, and they're recognizing that that value doesn't exist in terms of a health regard, just whether they have cavities or they don't. You see, the population is intelligent. They recognize that the proper physics position of their teeth can enhance their ability to reduce problems down the line. Medicine has done it, why can't dentistry? We have moved to the mindset of preventive medicine. And this is exactly what orthodontics delivers on a day in and day out basis. We are looking at many factors, many risk factors, and we're looking to reduce those to prevent issues down the line. And people are now looking to both accomplish that through understanding, but they want to also dovetail that with their quality of life experience while they're undergoing the orthodontics. And there is a larger shift to demanding aesthetic treatment modalities so that they can be cognizant of their issues, look to address them, but also doing it with a treatment mechanism that can work within their lifestyle. So I want to now move into what are the cases that are going to be successful for you, your team, and your patients come Monday morning. So the first thing is that we want to understand that there is no individual that is the same. Each individual is very unique. So if we are going to be looking at each individual and knowing what they require, using Dr. Andrew's 6 keys to occlusion as our foundation of where the teeth need to move, the next thing we need to understand are what are those cases that have a scenario that can work within this type of know-how. So generally speaking, class 1 cases, mesiobuccal cusp of the maxillary molar engaging with the mesiobuccal groove of the lower, and subsequent to that, the premolars and the canines being in a class 1 position, those are the perfect cases to start looking at, especially if there is mild to moderate crowding with no attachment loss, whether it be visible recession or horizontal bone loss or vertical defects. These are the patients that we should be looking to help. Mild class 2 cases where that mesiobuccal cusp of the maxillary molar is slightly mesial to the mesiobuccal groove of the lower. And I'll tell you a trick that will make this as a slam dunk analysis for you. If that upper maxillary first molar is rotated mesially and it looks like it is a mild class 2, as soon as you derotate that maxillary first molar, boom, you're going to be in a Angles Classification 1 scenario. So that is not a positional issue where the tooth has to be moved back or the lower first molar needs to be moved forward. That was a rotational issue. If you see that these maxillary molars are rotated mesially and that patient is slightly class 2, that's actually a masked class 1 scenario. And mild vertical components. So anything where the overbite for the patient is less than 3 to 4 millimeters of upper anterior overlap to the lower incisors. If it's 0, 1, or 2, where you have to just do some anterior closure, those are perfect cases for the aligners. So let's take a look at some examples. If we see Andrea over here, she presented with some mild crowding. She was in particular very interested in only having the lower treated, but we can see here that we can easily help with tooth number 7 or the upper right lateral incisor. If we take a look at her lower, this was really her main area of concern. She had a great starting position, very mild crowding, something that we can create space genesis with through conventional means of interproximal reduction to be able to align those teeth in the center of the bone and help her to achieve the alignment that she desires. Next is Kyle, who presented with tooth number 10 being too facial and slightly gingival. Kyle only wanted the upper to be corrected. This is something that can easily be accomplished with the aligner therapy. To be able to bring that upper left 2 into arch alignment and ultimately provide him that social smile that he would like. And you can see the intimacy of the aligners with the appropriate placement of the attachments. We were able to help Kyle to move along in that journey. And what I will tell you is that what you probably have already picked up on is Andrea only wanted the lower, even though there was an issue with tooth number 7. Kyle only wanted the upper, social 6, tooth number 10 to be corrected when there was arch alignment issues with the lower. Inevitably, when you help them to succeed and they see those results, they'll often come back to you and say, that looks great. What does it take to do the opposing arch? And ultimately, we're able to bring that tooth number 10 into position. And I also like to share here is that while as an orthodontist, I see a whole host of risk factors that are still present in terms of the bite and what were expressed to Kyle in terms of his comprehensive treatment option. What I've been humbled and have realized through time is something that my dad said, is that perfection can be in our mind. Perfection can be written in a textbook as what is quote unquote the ideal treatment outcome. But perfection for the patient can only be defined by them. So in this scenario where Kyle only wanted his upper teeth to be improved, we met in the middle by telling Kyle that your bite is far from perfect. So let's make sure that we get you into a night guard to properly protect your dentition until you decide to be able to comprehensively move those teeth into the right position. And just after 3 months, very simple process, we're able to align those teeth in a way that Kyle wanted. So let's talk about tooth movement. So generally speaking, if you're trying to gauge how long your aligner therapy will take, what you want to look at is the difference very simply between bodily movement and tipping movement. Tipping movements happen very quickly. And while I can't provide an exact amount because it depends on whether the crown is tipping itself, the crown and the root are tipping, or you're actually just tipping the root. What generally you can understand and base your decisions off of is that if it's a tip movement only, they occur quite quickly. And what is great for the patients is they also see that beneficial change rather quickly. When you're talking about bodily moving a tooth, then you should estimate those movements to occur about 1 millimeter a month. So let's take a look at a younger patient, Caleb. If we take a look at Caleb's case, what we can see here is that he has a mild deep bite scenario. Now, if we look at the starting positions of his molars, which is a class 1 scenario, this is a great case. Too often, it is missed as to what is the true etiologic factor of why this is a deep bite case. People are talking about posterior vertical opening, when in fact, actually this mild deep bite case comes back very simply to what we looked at in Andrew's 6 keys to occlusion. If you remember key number 3, the torque of the anterior teeth, you recognize and remember that those teeth need to be positively inclined. If you take a look at Caleb's case, those teeth are certainly not in a positive torque inclination. But when we move them into the right position, what happens? It's called apparent intrusion. That bite opens. So this is an absolute case that can be done using aligners. And it's all based on the fact that those upper anterior teeth do not have the proper torque. What we also recognize is that there is a post-ortho restorative opportunity of the upper laterals being too small. So you can imagine if we really are looking to help the patient for the purposes of not only delivering on the treatment outcome that the patient deserves, but also enhancing that patient experience, some of those patients could benefit from pursuing orthodontics within the restorative office. And having a healthy, strong relationship with our orthodontic teams enables these types of opportunities to continue to exist for our restorative dental offices and patients. Because you see, our understanding and advancement of the orthodontic profession yields us this opportunity to create an aligner product, an aligner software, an aligner know-how, and these types of opportunities to be able to share this information for the benefit of the patient in the restorative dental offices. By supporting those orthodontic practices, we're enabling ourselves to be further supported in what we know and what we can do for our patients. And there'd be nothing that would make me more happy than to have an individual like Caleb be treated in a restorative dental office with the orthodontics, the post-ortho restorative, to help minimize finances, enhance patient experiences, all the while ensuring that the treatment outcomes are going to be predictable, long-term, and stable. Let's take a look at Mac. Mac had treatment through direct-to-consumer process and was not happy with his outcome. Mac presented with a mild open bite. I mentioned that ideally our overbite should be about 3 to 4 millimeters to give us the proper protrusive runway ramp to ensure that we have mutually protected occlusion. But we also can see that there is a mild crossbite too on the lower right canine. This is a perfect case where we have a class 1 occlusion in the posterior to be able to help with that limited type of tooth movement. When we take a look at the upper and lower occlusals, specifically the lower occlusal, if we take a look at that lower right canine, we can see that it is mesially rotated out or facially, which is going to be contributing to the positional issue that we are seeing when looking at the anterior bite and seeing that that tooth is in crossbite. By tucking that back in, we're not only going to be helping to correct that crossbite, we're also going to be putting that tooth in a more favorable position with the underlying attachment apparatus, which is going to be the gingiva, the dental alveolar bone, and the basal bone. This is Kim. Kim presents with this type of occlusion. and wanted to have her lower anterior teeth to be corrected for the crowding. And this is what we were able to achieve for the alignment of those teeth with 7 aligners. This is what it looks like from the occlusal view, specifically looking at just the lower occlusal. What you can see here is with 7 aligners, 5 months, including a pandemic, we were able to achieve the correction of those lower teeth. And this is demonstrative of exactly what I was referring to before, that when you correct one arch for patients per their request, they'll often come back and ask for treatment on the upper. And that's exactly what happened with Kim, is that she was so happy with the treatment that she had on the lower anterior teeth, she's now looking at the upper anterior teeth. And slowly but surely, step by step, she'll begin to understand the value of a bite correction beyond just alignment. But by not only hearing what our patients are saying, understanding and looking to help them to deliver the care in the process that they want, while all the while making sure that you're informing them fully. Kim was fully informed about the comprehensive bite correction and the benefits of that. What you are doing is you are enabling them to take control of their process, but slowly but surely advancing them to the end goals that you want for them. Nimit. Nimit was a scenario who he had some orthodontic care, but the finishing, the timeline, the experience with work really precluded him from sustaining a fixed appliance journey alone. So he wanted to have his bite correction with aligners, or at least the finishing of that. And this is a perfect case to be able to do with aligners. So really in a restorative dental office, how does that play a role if the fixed appliances were something that the orthodontic team did? Well, especially in our area of Princeton, New Jersey, we have a lot of people coming to the area and then leaving. If this was the case that came into your office where they were a transfer into your area, this is something that you could really help them out with in terms of finishing that case. And you can see that the general alignment for the teeth looks good. It's really just a component of the posterior bite closure. A quick caution and recommendation for some of the factors that you will see clinically where you would want to look to engage your orthodontic team. A case that really has a lot of hidden risk factors that's not setting your restorative dental team and the patient up for success for doing orthodontic therapy within your office, but also an opportunity to strengthen and build the relationships with those orthodontic practices. So if we take a look at Anu's case, what we can see in the intraoral photographs is the anterior proclination. We can also see that there is a crossbite in localized areas, as well as recession. And the restorative dentist had shared with us that generally her periodontal history was sound, and she found that she didn't have periodontal pathogens play a role in the attachment loss, and wanted us to further investigate that for Anu. When we take a look at the upper and lower occlusals, what we can see is that there's wear. There's certainly a prominent frenum that may be perpetuating the diastema between the upper central incisors, and then spacing on other parts of the upper and the lower arches. If we take a look at the panorex and zooming in a little bit closer, what we can see is that there's generalized horizontal bone loss. And with the periodontal history of what the restorative dentist had said about the fact that she had good oral hygiene practices at home, this would be something that's certainly concerning. What we ultimately figured out is that the teeth were not properly positioned within the cortical plates. They did not have a proper torque on the lower teeth, which was actually stressing, creating areas of compression on the bone, which was exacerbating the bone resorption that she was clinically experiencing. And what we began to understand through careful diagnostics is that her skeletal transverse relationship between the maxilla and the mandible was non-ideal. And as a result, what we see in that red area was that the upper maxillary molar was pushed too facially against the facial cortical plate. And as a result, the health and longevity of the maxillary molar and the underlying bone was at risk. When we took a look at the lateral ceph tracing and looking at the position of the anterior teeth, we could see that the upper central incisors were also pushing against the buccal cortical plate. And when we looked at the options for her, we found that orthodontics alone could move those anterior teeth back, but it required great precision. And then the other option was surgical orthodontics. So this is the type of case, if you see clinically that the etiologic factors are too large in number or not clear in terms of what the presentation is, this would be a case that would benefit from the expertise of your local orthodontic practice. I'd like to end with some case submission tips. So we now understand how to set up our occlusion, where to move the teeth, what we're looking for an ideal outcome. We also understand on Monday morning, which are the patients that we were going to be able to see, and probably you see them on a daily basis. And hopefully today are now able to identify them as good candidates for orthodontic aligner therapy within your hands and your practice. The next is, how do we communicate all that information effectively to the lab? So as I mentioned, in our practice, we leverage the benefit, the utility, and the robustness of the SureSmile platform. And in that SureSmile platform, the most effective way to work with our patients and to be able to communicate what they need is through what's called the macros. And what I love about the macros is it distills out some of the most important features of any patient's bite and their needs and the way that we want to go about addressing them. So let's go through that. When you click on the midline, you have the option of telling the lab exactly where to place those midlines. What I recommend is to tell them exactly where the midline exists and how you would like that coordinated with the face. The next is the arch form. Are you going to be correcting that? If so, how and in relation to what? What is the molar classification? How do you want it corrected? Is this something that can be corrected to a classification 1? If we're identifying our cases correctly within the restorative dental office, then we should always be looking at correcting that to a classification 1. As a general kind note, what I'd circled there is that we want to be speaking in the Palmer notation. Finally, resolutions, which is the space management. How are we going to create space if we have a crowded situation? What is the magnitude of the interproximal reduction that we feel is safe? Those important directions will help the lab to be able to simulate the tooth movements that you are requesting for that patient. The next is the occlusal plane. Are we going to maintain that? Is it actually a deep curve of speed? Do we need to level that further? And finally, any special instructions. So is there a true size discrepancy? Do we want to leave space for augmentation restoratively of those upper lateral incisors? And how do we want our trays to be? And that's what we really love about the SureSmile delivery system, is that we get to customize that. Is it going to be straight at the gingival margin? Is it going to be straight past the gingival margin by 1 millimeter, by 2 millimeter? Do we want it scalloped for those individuals that are going to have issues putting them in and taking them out? What do we want for attachment templates? Do we want them scalloped so that our team can easily insert them and then easily remove them when those attachments are placed? And then finally, the case setup. We're telling our digital lab that we want this to be set up with the final outcome such that we have met Andrew's 6 keys to occlusion. We want that key number 1 of the mesial buccal cusp of the upper maxillary molar to be engaged with the mesiobuccal groove of the mandibular first molar. We want to make sure that our crown angulations are such that the incisal edge or the occlusal edge is going to be slightly mesially tipped to the gingival portion of the clinical crown. We want to make sure that our crown inclinations or the torque of the upper anterior teeth are going to be such that they're going to be positively torqued, and in the posterior teeth that they're going to be upright or slightly lingually inclined so that we have a proper curve of Wilson and we're not introducing any non-working interferences. We're going to make sure that we have no rotations, no spaces, and a flat occlusal plane. This simplifies a process that in an accurate, diligent, and thoughtful digital workflow that we do day in and day out with all our orthodontic patients that leverages CBCTs, accurate scans, comprehensive orthodontic diagnostics, a robust diagnostic and treatment planning software platform of SureSmile, and an execution delivery method and treatment modality of SureSmile aligners that we can consistently, predictively yield the quality results that all of our patients deserve. And hopefully today's discussion enables you to do the same for your restorative patients requiring orthodontic care. And may today also be the first day forward to strengthening that relationship with your orthodontic practices. Because you see, when we all grow, we all benefit. And ultimately, when we provide that accuracy to our patients, we're not delivering only on an expectation of ourselves from our team, but we're also delivering on the lifelong smile that our patients are going to love. I want to thank you for the time. While I would have always appreciated the privilege to see you in person, I will take this virtual moment as my blessing for us to engage, and may you provide meaningful care by love and through orthodontic therapy for all of your patients.